Thank you very much, Sue, and thank you everybody for joining me this evening to discuss a dear topic to my heart. I think pulmonary hypertension is an underdiagnosed disease. It exists among a lot of patients that we see in pulmonary medicine practice. It is just a disease that we have to uncover whenever we suspect it, and it comes in association with a lot of other illnesses as well. My objectives today are basically to go through what is pulmonary hypertension? How can we simplify this complex disease that one group of it is actually quite rare, but there are many other groups that exist among us. I will try to go through the physiology of pulmonary hypertension, simplify as best as possible how we approach patients and define if they have this disease or not. And then I will touch base on principles of management and enrich all of us on what's available to us nowadays for management of this disease, depending on the group and type of the disease, which is an essential step. It is very hard to cover everything in 50 minutes or less, but I will do my best to touch on the principles and make the understanding of the disease is quite there to all of us in the community, so we know how to help patients and seek advice when we have to. Starting with the physiology of the human body, I'm going through the cardiopulmonary circulation, how blood flows between the heart and lung and where we receive it from the rest of the body. So if you think about the heart as four rooms where we have the right atrium, right ventricle, the left atrium, left ventricle as outlined there. The blood on the left side of the screen is representing blood that is coming from all over the body. Imagine the systemic circulation on the left side and the pulmonary circulation is on the right side. So when we receive blood from all over the body, it comes from the systemic veins through two different veins, the inferior vena cava and the superior vena cava, and it reaches to the right atrium, and then it goes through to the right ventricle. The right ventricle then pushes blood through the pulmonary artery to the rest of the circulation, and there are numbers that appear on the screen. This is what we expect of normal circulation on average in the United States and Canada. And as it goes through the lungs, it spreads into pulmonary venules and capillaries, and it reaches through smaller branches to allow gas exchange. So the lungs would take the carbon dioxide that is delivered from all over the body, and then we exhale that. And then oxygen that was inhaled from the air through the airways, and it splits all over until it reaches the pulmonary capillaries, will return blood to bright red that is really nice and well oxygenated. And then the pulmonary veins will return blood to the left atrium, then to the left ventricle, and then the left ventricle would push blood to the rest of the body. So that completes what we call the heart and lung circuit. And that's what we expect to happen in a normal circulation. Now, when a patient develops pulmonary hypertension, it is usually a disease that happens to affect this area of the pulmonary artery. The pressure here rises significantly. And as you would imagine from this diagram, that the problem can be genuinely in these vessels or capillaries, or it could be from rise in pressure from a lot of fluid in the pulmonary veins, and that will result in a reactive squeeze from the pulmonary artery. So we overcome the stagnation of blood, and then the circulation continues. Otherwise, the circulation will stop and the patient will die. So in order to avoid that, the pulmonary vessels and capillaries are really smart, where a squeeze will raise that pressure here if there is a lot of fluid. But we come to situations where the pressure here rises by itself without having a lot of fluids in this side. This is why, and I will go through this later on through my brief review today, how we call the disease pre-capillary or post-capillary disease, which means, is the pressure in the pulmonary vessels rising because of genuine issues in the pulmonary arteries and capillaries, or is it rising because of problems of fluid and rise in pressure from the pulmonary veins? So pulmonary hypertension, as you would see, because the circulation is all inside the heart and lung, we cannot confirm the diagnosis without doing what we call a right heart cath. And I will explain that simply in the next few slides. The suspicion increases usually with certain symptoms that when it comes, it's particularly unexplained shortness of breath with inclines, but really the patient is doing okay on flat surfaces. And we're not going to do right heart cath right and left on every patient because it doesn't make sense. So we look for signs and surrogates on an echocardiogram that is usually done for the patient that we suspect they might have a pressure that is rising in the pulmonary circulation. And in order to evaluate things carefully, and I mentioned two big groups in pulmonary hypertension there, where is it related to a lot of fluid or is it related to a genuine problem in capillaries? If we end up treating patients with any kind of medicine that is primarily driven for precapillary disease and the patient had problems with a lot of fluid, they actually do worse. This is why evaluation of this disease is important in a specialty clinic, in a pulmonary vascular disease clinic, like what we have here at Baystate, on the western side of Massachusetts. On the eastern side, there are other great centers as well. And then we decide, based on reviewing all parameters, the associated illnesses, if we need to proceed for this invasive procedure called right heart cath. And it's not risky, but it's also not ideal that we proceed on everybody. So say a patient has problem with a lot of fluid. This is what we call left heart failure. It's basically a representation of a problem on the left side of the heart. That could be because of weak muscle, like patients who have cardiomyopathy or weakness in the heart structure. It could also rise because of arrhythmia or atrial fibrillation. That happens because of rhythm issues in the left atrium. This is the mitral valve representation, where if it has narrowing or regurg or something, sometimes, and we see a lot of this, patients may come with stiffness of the heart muscle. We call it diastolic dysfunction, or you may have come to a term called heart failure with preserved ejection fraction. So all these will make a situation where the pressure in the left atrium will rise, and that pressure will stagnate the blood in the pulmonary veins, and then it will reach to stagnate the capillaries in the lungs. Then the pulmonary artery will squeeze to make the pressure and the blood flow go through these capillaries to reach the heart still. Otherwise, it's not going to work for the patient. But as you would imagine, when we have a rise in the pressure here, that will result in a lot of strain on the right ventricle, and then the right ventricle swells. And this is what we face in patients with pulmonary hypertension because of fluid overload. They end up having shortness of breath that comes when they lie flat, shortness of breath that wakes them up at night. And if it gets too bad, it gives them the shortness of breath at rest. And this is what we call pulmonary congestion or pulmonary edema, which is a form of pulmonary hypertension, but it's pulmonary venous hypertension, as you would imagine, because of the rise in pressure and volume there. So that rise helps the patient. And in patients who have genuine problems because of the right side of the heart, and this happens because of unknown reasons why the pulmonary artery raises that pressure. It can happen in patients with also an underlying lung disease like COPD, if it gets too bad with a lot of emphysema and it destroys the lung function with time. The pressure also rises here. Patients with underlying interstitial lung disease or pulmonary fibrosis, they may end up having this genuine rise in pressure without a rise in fluid. We call this precapillary pulmonary hypertension. And it can be the idiopathic process where the pressure rises because of unknown reasons and factors, but it's there. There are some associations I will mention as well. That pressure rise will strain the right side of the heart because now, as the right ventricle is trying to push blood through the pulmonary arteries to have the gas exchange and we get rid of CO2 and we get the oxygen, now the pressure here is up. So the right ventricle is trying to squeeze hard. So it swells up. And that swelling will result in the shortness of breath, lower extremity edema, abdominal swelling, what we call ascites, pleural effusion sometimes. But typically, if the right side of the heart is alone affected without problems on the left side of the heart, they wouldn't have shortness of breath lying flat or shortness of breath that wakes them up at night. So it's unlikely that patients with isolated right-sided heart problems because of pulmonary hypertension of precapillary type, that they have pulmonary edema. And this is why it is important to differentiate both so we know how to apply the right management accordingly. How common is this disease? Well, in the latest reviews and statistics, the idiopathic form of pulmonary hypertension that has no known cause, associations, it may run in families, there are some genetic predispositions or association with certain autoimmune diseases or connective tissue diseases. This is what we call PAH. It runs in about 24 to 28.7 cases per 100,000 population per year, and this number was rising with more awareness from rheumatologists, from physicians who take care of certain diseases, where they started screening patients better with an earlier echocardiogram. Then we ended up identifying patients early. PAH is a disease that tends to happen more in females than males. We don't know the etiologies behind that, but it's one of the documented causes. However, what I want to point out that pulmonary hypertension in general represents about 2.6 to 8.3% of a population. And I'm not saying all of them have PAH, the idiopathic form that we worry about and we want to catch people early and treat them. It's mostly related to pulmonary venous hypertension where there is fluid overload and we need to treat patients. But there is a good portion of patients who have an underlying undiagnosed lung disease that comes with association with that. A good proportion of patients have a sleep-related breathing disorder. It is typically more than just obstructive sleep apnea, but it's important to screen patients for that anyway. Patients who have clots that have developed from pulmonary embolism and they never dissolve, they end up having this disease as well. And this is further grouping or classification of pulmonary hypertension. Group 1 is basically the conditions that results in precapillary involvement of the pulmonary arterioles, and it can be idiopathic, but I generally recommend that a lot of patients with an underlying autoimmune disease or connective tissue disease get screened for the presence of any elevation of pulmonary pressures. The classical example of connective tissue diseases is scleroderma or systemic sclerosis that can come in a limited or a diffuse format leading to this. It's also common to see patients who have HIV disease develop pulmonary hypertension. So it's important to screen these patients with at least an annual echo. Patients with an underlying history of congenital heart disease, anomalous venous return, some sort of old surgery when they were kids or something that might be associated with late development of pulmonary hypertension as well. There are a list of medications that can lead to pulmonary hypertension. I'm going to talk about that in the next few slides. What really important to keep an eye on is that a lot of left heart disease patients, as I explained earlier, valvulopathies, AFib, systolic, diastolic heart failure is what we commonly see as a cause of pulmonary hypertension. followed by people with underlying lung disease. And the latest discoveries we had about being able to help certain patients with lung disease associated pulmonary hypertension with medications is what we want to catch, so we actually help them to maintain their stability and prevent their progression and deterioration. And those are the patients with underlying interstitial lung disease, where they really need some sort of screening for an echocardiogram at least annually, especially if they are in need of oxygen or if they know that their lung disease is progressing, just to know how we can stop that and help them. Now, chronic clots that never dissolve. Fortunately, a lot of patients who have pulmonary embolism, they end up having resolution of clots, but there are these 2 to 3% of patients who never dissolve these clots, and they end up forming a stagnation of flow in the pulmonary arterioles, leading to pulmonary hypertension. We need to find these patients early and identify what works for them best, whether it's medicine, procedures with balloons, or maybe surgery in the right center. This is just a list of subdiagnoses that are derived from the latest European Society of Cardiology and European Respiratory Society guidelines that were published in 2022. As you can see, a lot of associated illnesses are reported with that. And when we talk about group 3 pulmonary hypertension, in addition to restrictive lung diseases and maybe obesity, hypoventilation syndrome, we really want to pick up patients who have an underlying interstitial lung disease, as we could help them with additional therapy. What do we mean by screening with an echocardiogram? So this is for people who had the chance to see me in clinic. I usually pull up the echocardiogram and show them this picture. And I'm not a cardiologist, but I learned how to look at the important views in an echocardiogram to help us understand why pulmonary hypertension should be suspected. So this is an echo for one of the patients I have seen in the past, where you can see that typically the left ventricle is bigger than this. It occupies about 2/3 of the space of the ventricular system, while the right ventricle here is usually about 2/3 of the size of the LV, but you can see here that the situation is flipped. We see dilation of the right ventricle, and when we apply Doppler signal that allows us to see the flow of blood, you will see a lot of regurgitant jet in this area, the tricuspid valve. And when we see dilation of the right ventricle, some sort of immobility, a TR jet velocity that is increased, it is only rising here because there is difficulty of this room to push blood through the pulmonary vessels, so there is a rise in pressure. That's how we predict there is something going on. Other signs we look at, we typically want with any contraction of the left ventricle that the septum pushes this way and then it goes the other way with relaxation, but it's not able to go there because there is a lot of pressure here. So it's another sign that tells us we have to really assess the patient and see how things will progress. And I would love to see patients at this stage before they reach this stage. This is a severe form of pulmonary hypertension. You can see how big is the right ventricle, and the apex of the heart that usually controls a lot of contractility is typically predominated by the left ventricle because it's the stronger room that wants to push blood to the rest of the body, while here the pressure that is raising is just keep accumulating until it was pushing on the LV and the patient here wasn't able to do anything without getting short of breath. Now, this is a concerning echocardiogram, and it's concerning because when we reach that stage, it's too late. And we sometimes are not able to help patients at that stage. And this is why I highly advise that we screen patients as soon as possible whenever there are associated illnesses to make sure we catch them early. This is what we mean by a heart cath. And from the diagram I described earlier, you could imagine that we try, it's literally like a long IV that has a balloon at the tip. And the idea of this is that we are trying to measure the pressure in 3 rooms and take a surrogate pressure as we try to seize the flow with the balloon reaching in a branch of the pulmonary artery to represent the left atrium. And what matters to us by getting these 3 or 4 readings is making sure, one, that we have high pressure in the pulmonary artery, because seeing is believing, and without knowing for sure, it becomes difficult. And when we get the pressure in the left atrium, we know, is it a problem because of the left side of the heart and the left atrium has a lot of pressure? Or is it a problem on the right side of the heart without the left being involved? And therefore, we need to look carefully into the patient more and more. I don't want to bombard you with this slide. I just want to make sure you know that there are lots of familial and genetic and hereditary associations with pulmonary hypertension, particularly BMPR2 receptor that runs in family. There are SMAD mutations, CXCL2, lots of other genes that are involved, the caveolin gene as well. But it's just helping us to understand how it may run in families. So you may see patients with heritable PAH with a lot of BMPR2 mutations, and it keeps running in the family. And that's why we screen patients. I talked about medications that can lead to development of pulmonary hypertension. Some of them are quite old, like fenfluramine or dexfenfluramine. Those are quite old medications that were used for management of weight loss. Some people wanted to lose weight with medications, and these are 2 that are well known to do that, but they are also pulled out from the market because they lead to development of pulmonary arterial hypertension that I know a lot of patients, and I took care of a lot of patients who needed to maintain on 3 different kinds of medications to keep the pressures in good control. But we also keep in mind that there are newer medications like methamphetamines and amphetamines, and there is a lot of use of these now for ADD control. Now in ADD, we use quite low doses, so they are safe, but sometimes we end up abusing and use higher doses of these medications. So you want to be careful about that. Without a physician advice, it's not advisable. There are other medications out here that were associated lately, like chemotherapies for malignancy. So these are 2 famous agents that had been associated with development of pulmonary hypertension. Dasatinib is a tyrosine kinase inhibitor that is used in chronic myeloid leukemia patients, and it actually can lead to pulmonary hypertension. So if any patient is on that medicine, will need screening. And it is just important to remind your doctor about the possibility of this if you are taking any of these medications or someone who is. Now, let's focus a little bit on symptoms. Generally speaking, and a lot of physicians think about pulmonary hypertension when they run investigations for a patient who has shortness of breath and cough, and they couldn't find the cause. And then they think about this disease and refer to a center. So unexplained shortness of breath is a common thing that people look at. However, if there was an explanation in an X-ray or a breathing test, or maybe through seeing a cardiologist, people usually don't think about that. What's really important to keep in mind that shortness of breath can have a presentation in asthma patients. It can happen in lung fibrosis patients. It can happen in heart failure patients or pulmonary hypertension patients. So how can we differentiate? What's really important to understand that pulmonary hypertension is not a sudden disease. Nobody comes all of a sudden with pulmonary hypertension symptoms. It typically happens over months, and it slowly develops over time. This is why screening is important when we know there are conditions or illnesses that can be associated with this disease. What's really tricky, if we focus on things that a lot of patients earlier in the disease, in the milder stages or forms, they don't have shortness of breath walking on flat surfaces. Like they could walk a block or 2 without any problems. But whenever an incline happens, then it catches them. There's something going on. Climbing stairs. Now, I realize we all get some degree of breathlessness or shortness of breath when we climb 2 stories or 3 stories of flights, but those patients, they tend to have it even at a half a story or half the stairs before they reach the first level or the second level from the ground. It's classical that shortness of breath happens with bending over in any form of heart failure. Like if the patient has pulmonary hypertension and then they bend over to get their keys that fell off the ground or groceries and they try to bend and get them up and stand, then it catches them. They feel that degree of shortness of breath and lightheadedness. And also, it happens to be in association with physical examination findings that are notable, like commonly leg swelling. Leg swelling can happen because of heart conditions, pressure in the lungs, and other conditions as well, like a liver disease or patients who have some high protein in urine. We call it nephrotic syndrome. So all these are possibilities. But if there are none of these and we really need to make sure, then it could be a very silent sign that there might be something going on. Now, if it gets too bad, the fluid gets accumulated around organs in the belly, then abdominal distension happens and fluids tend to cause what we call ascites or fluid accumulation in that. Now, what's really interesting that some patients with underlying liver disease may develop pulmonary hypertension as well. So this is also something to keep in mind for screening. So we did the screening possibility. We did some education and teaching on finding pulmonary hypertension in associated conditions like connective tissue diseases, HIV we talked about, certain high-risk medications, patients with underlying chronic lung disease, particularly interstitial lung disease, should have a very low threshold to investigate and screen for the presence of pulmonary hypertension. Patients who have a history of blood clot or sometimes without that history, we always screen them for the presence of chronic clots because the treatment pathway is different. So our job when we get a referral for evaluation of patients with pulmonary hypertension is that we try to identify which category they fall at. And you can see here that a lot of the focus was really on determining if they have left heart pathology or abnormalities, because it is by far the most common cause of pulmonary hypertension because of a lot of fluid. That's the post-capillary component. But there are patients who get history of blood clots, and we talked about that, and they end up developing non-resolving clots, so they stay on the wall, they prevent the flow of blood, so that results in backward pressure elevation, and that leads to swelling of the right side of the heart without any problems on the left side. We call these chronic thromboembolic pulmonary hypertension, or CTEPH. Now, if we have a patient who has CTEPH, the direction of management is quite different than those who do not have that disease. There are patients, and we have heard a lot of our colleagues, neighbors, and friends having what we call COPD. It's chronic obstructive pulmonary disease. It's a combination of chronic bronchitis that leads to a lot of coughing and shortness of breath, or emphysema, where the alveoli really get enlarged and they form cysts because of smoking-related lung damage. Now, some patients may develop what we call pulmonary fibrosis or interstitial lung disease because of autoimmune conditions or sometimes without known factors. And interstitial lung disease patients are important because they, generally speaking, tend to progress. We sometimes are successful in holding disease progression, but that progression of symptoms and deterioration can be because of associated pulmonary hypertension. And nowadays, we have an inhaler that can help them to get over it and recover from this, but it requires careful investigations and analysis as well. Now, there are patients who develop the idiopathic pulmonary arterial hypertension without any other airway-related disease or parenchyma or tissue-related disease. And those patients are also of a primary focus because we want to catch them early and make sure we put them on the right treatment. So what is the right treatment? Before I go into specific managements, there are general measures that I try to talk to patients about it, because not only they are important to keep things stable, they are important to assure success of treatment as well. It is very important to understand that diuretics are important for patients with pulmonary hypertension of all kinds. If fluids are accumulating in the body, generally speaking, patients don't do well. And even if we put them on all the medicine in the world, it may not work as it should be. And diuretics are important to be taken. And there are also no fixed doses of diuretics. We usually talk through that with patients. As we get to know them better, we usually put them on a target body weight, and they have a scale at home that we advise them to have. And they generally weigh themselves on daily basis and make sure that if they gain 2 pounds or 3 pounds overnight, nobody puts fat in one night. It's likely fluid that we need to take care of with extra pill of diuretic or something. Second important thing is oxygen, and oxygen is very important to prevent the patient from having reflexive vasospasm of these pulmonary arterioles. And lack of oxygen and rise of carbon dioxide is the most potent vasoconstrictor of the pulmonary vessels. It is the most potent reason why those vessels clamp down and the pressure then goes up, and then the right ventricle swells, which is what we don't want. Now, in patients who have chronic clots, as you would imagine, they will have to stay on a blood thinner. And without this blood thinner, then they have the tendency to form more blood clots. So that's important to keep in mind as well. Now, some pulmonary hypertension patients may develop because of the swelling in the right ventricle, the right atrium gets swollen. It kicks a process of arrhythmia or AFib, and then they may end up having a risk of getting a stroke or occlusion of a clot that goes anywhere. So we also put these kind of patients on a blood thinner. We usually screen for anemia because patients with pulmonary hypertension of any kind, they end up having lack of appetite, they don't eat as well, so they go into iron deficiency anemia, and that makes their situation more difficult. And there are recent studies that showed in fact, lack of iron is common in heart failure patients of any kind, whether it's right-sided or left-sided. And if we don't fix their anemia or at least their iron content, they may end up having a problem. I can't emphasize enough on the value of salt and fluid restriction in patients with pulmonary hypertension. Now, fluid restriction is just we don't want to have more than what a sick heart can handle. And if that happens, then we get up adding more pressure on already a problem that exists, and that results in failure of recovery of that swollen heart. And that failure can be permanent. And this is why we always talk about fluid restriction, and typically between 60 to 64 ounces of all liquids a day for patients with any kind of pulmonary hypertension is important. Adding to that salt restriction. So sodium tends to keep fluids inside and it prevents excretion of that. So it causes more stagnation of fluid, more retention of fluid. So sodium is not a friend for any pulmonary hypertension patient. So we go through these lifestyle changes and important measures before we talk about specific therapy. So in patients who have pulmonary arterial hypertension, we typically focus on one of 3 lines of therapy, and you will hear us talk about that for PAH patients. We talk about a nitric oxide pathway, an endothelin pathway, and the prostacyclin pathway. And we have parameters that we follow that includes a functional status assessment, how much the patient can do, and that define for us, as well as other investigational criteria, mainly findings from right heart cath and checking a blood test level called proBNP, which reflects how much stretch we have on the heart myocardium, how many of these pathways we need to add. And some patients feel quickly better, but we still keep adding therapy because objectively, through assessing the echo and this BNP test, in addition to their walk test, which is a very important thing to look at objectively for assessing functional status of patients, it will tell us where we stand and are we really in a happy area or not. And I will just throw in here some examples of medications so you guys are aware. For the nitric oxide pathway, if the patient is in an ICU or something, we could give nitric oxide to help relax the pulmonary circulation, or give medications that decrease basically the metabolism of endogenous nitric oxide, like sildenafil and tadalafil. ERAs are endothelin receptor antagonists, and we have three medications that we consider using. Bosentan and macitentan work on both receptors, ETA and ETB receptors. Ambrisentan works on only ETA receptor. Clinical trials have shown that targeting one or both will actually result in significant reduction in pulmonary hypertension. Prostacyclins, we have a lot of them. Treprostinil is commonly and widely used, and it is fortunate to have treprostinil in a lot of formulation. We can actually give it IV or subcutaneously. It can be given as a nebulized inhaled therapy. We have also a dried powder formulation of it that can become convenient for PAH patients. And there are oral pills as well. An older prostacyclin, it's called epoprostenol, and it has two names. You may have heard them, Flolan or Velletri. They are also efficient and effective, but it's an IV medicine. So treprostinil intravenously or Velletri and Flolan, they have to go through a pump all the time. Riociguat is one of the newer medications that we learned to work through the nitric oxide pathway. The trade name is Adempas, and it is mainly used in patients with group 1 pulmonary hypertension or group 4 who are not candidates for surgery. And there are patients who are doing well on Adempas. This is the only medicine that we can use in group 1 and group 4 disease. For Selexipag or Uptravi, it's a medicine that is also available, and it's a very good and strong, potent medication, and it's a pill that we usually add to a medication from this side and another side, or sometimes we use it alone if there was any intolerance for PAH patients. Now, inhaled treprostinil is something that we found lately, and I'm going to talk about that in the next slide, that has been found to help with careful assessment and review of a patient who has interstitial lung disease and also pulmonary hypertension. And this is why screening these patients is helpful. This is the study that I'm pointing at for patients who have an underlying interstitial lung disease. The group of patients who received inhaled treprostinil did very well with improvement in their functional capacity compared to those who had an underlying lung disease and they were just on a sham medicine, but it wasn't giving them the benefit if they had an associated pulmonary hypertension. So for patients who have an underlying interstitial lung disease, it's really important to see if they could benefit from this if they have pulmonary hypertension. And this requires careful assessment in a pulmonary hypertension center. This is one of the newest discoveries in the world of pulmonary hypertension, where we found that acting through inhibition of the BMPR2 receptor, we may actually get additional benefit on the three other lines of therapy that we have for pulmonary hypertension. And I only post this here just to tell you, for PAH patients, we have a lot of things that we can help with. For those who have an idiopathic disease, and it's a disease that can happen in young patients, and we would like to save them before they deteriorate and get worse. And the future is bright. We have a lot of things that are being tested and investigated for. I don't want to bombard your head with a lot of this, but it's just research is ongoing, and whatever we can do to help patients is always there. Seeking and reaching out to a specialized center will be always helpful to see what we can do for any kind of patients with this difficult disease that needs careful assessment and making sure that we can take care of patients. I finished in less than 50 minutes with an idea to allow for answering questions and thoughts from the audience, and I'm happy to do that now. Thank you for listening to me.
That was really brilliant, and I applaud your work. And it's great to know that you're working so hard on future remedies for this. We do want to open it up to Q&A to our audience. And by doing that, you can just type your questions into the Q&A box. Our first question is, what's life expectancy with PH, and are there surgical options for treatment?
Thank you for asking this question. And, the life expectancy of a pulmonary hypertension patient is different now compared to before. And it really depends on the cause of the disease. What is the group of the illness? So if pulmonary hypertension was because of fluid overload, then prognosis and life expectancy counts on the situation that led to fluid overload from the left-sided heart failure. If it was from group 1, where idiopathic PAH is what we have, fortunately now, and I remember when I started doing this 15 years ago, the treatment that we had was not a lot of therapies except IV Flolan and maybe 1 or 2 pills. And patients, generally speaking, don't do so well, and we end up sending them to a lung transplant center. But thankfully, over the 15 years of developments and recovery now, it is rare that we send a patient to lung transplant because we have so many medications and we can help patients early. Surgical options for treating pulmonary hypertension exist for group 4 disease, patients who have chronic clots that end up leading to pulmonary hypertension and they never dissolved. So we usually carefully evaluate every pulmonary hypertension new diagnosis or referral to screen for the presence of undissolved clots, or what we call CTEPH, chronic thromboembolic PH. If they do have it, then an evaluation by a specialized center is important to decide, are they surgical candidates or not? Because if they can get surgery that results in cure, it's way better than doing procedures and medical therapy for this disease. And this is why it's important to screen these patients.
Thank you. The next question, which type of PH is most common?
So as mentioned earlier, and thank you for asking this again, pulmonary hypertension because of left-sided heart problems is the most common. So it happens because of high volume or high fluids in the body that generally happens in the heart and lung situation from left-sided heart disease. Followed by lung disease, where patients who have severe forms of sleep apnea that leads to lack of oxygen at night, obesity, hypoventilation syndrome, patients with underlying interstitial lung disease, chronic obstructive pulmonary disease. So those lung disease category, they come after. And then we have, depending on the area of where we live, it's either clots in the lungs or PAH. It seems that still around the United States, the group 1 pulmonary hypertension remains the issue, where we need to find an associated illness and treat them for that. And then we have to make sure they don't have clots, because we want to catch every opportunity to cure the patient instead of just adding medications.
Very good. Thank you. The next question, are there other warning signs beyond the shortness of breath?
That's a great question, and thank you for asking that. Yes, and what worries us, in addition to shortness of breath with exertional activities, signs of lower extremity edema, is what we call syncope, or sudden loss of consciousness that is breathing related. So a lot of people may have syncope because of a stroke, God forbid, or something else. They may have syncope because of lightheadedness, vasovagal. But if syncope happened in association of doing an activity and there was shortness of breath that the body couldn't handle, and then the patient would lose consciousness for 2-3 seconds, that's always a worrisome sign of pulmonary hypertension, that it is so severe and we need to address it quickly.
Very good. Thank you. And the next question, what causes high blood pressure when taken on left arm and normal blood pressure when taken on the right arm?
That's an interesting question. It is probably not related to the topic of the day. I advise we try to consult with cardiologists or vascular surgeons about this, just to make sure there are no anatomical problems between the left and right circulation on the systemic side. So this is more of a systemic vasculature problem.
Yeah, maybe their question was related to, that pressure that you were talking about with the top and the bottom, and maybe they thought it was arm related as well.
No, it's typically, and this is from general medicine. It's not really related to our talk today.
Oh, very good.
Top number of pressure reflects the power of blood coming out of the heart. So it reflects the left ventricular pump pressure power, where the bottom number reflects the vascular resistance, the tone of the arteries as they deliver blood to the rest of the body. So that's the top and bottom. But I wonder if the question was to say if the top and bottom were certain number on the left side, and then they were significantly lower on the right arm, then that needs a special evaluation by cardiologists or vascular surgeons.
Very good. Thank you. What about regionality impacts the chance of getting a particular type of pH? And I think you mentioned regionality as far as whether clots or something else in your last answer.
Yeah, so chronic thromboembolic pulmonary hypertension tend to happen in high areas where venous thromboembolic disease is more prevalent than other areas. And that's why if DVTs or PEs are common in areas of living, then you should expect more chronic thromboembolic disease or pulmonary hypertension to be in that area. If there are areas of the world where connective tissue diseases are more common, then we should expect more of pulmonary arterial hypertension to be something to look at through screening these kind of patients.
Very good. The next question, what's the average age of PH diagnosis?
Depending on the group. So for group 2, which is the most common, that depends on the cause. So we see mostly patients in their 50s, 60s or above with heart conditions that lead to volume overload and then pulmonary congestion and then pulmonary hypertension. While the rare group of pulmonary hypertension is PAH, but it happens typically in the younger age group of females more than males for unknown reasons. But it can happen as young as 20s, sometimes in kids and children too.
Wow.
Thankfully, not that common, but it can. And it peaks typically between 20s, 30s, or 40s of age, and then it comes down. With an incidence, as mentioned earlier, about 28.7 per 100,000 is so around 30 in 100,000 for the idiopathic rare form. We see more and more as we screen early. So that's why it's important. And if we detect it early, we can actually control it easy with a pill or two, compared to waiting until it's too late and then we need infusion medicines and pumps and stuff like that.
Oh, well, thank goodness you're catching so many so early. That's fantastic.
I hope we deliver the message of looking early as best as we can.
Right. Well, I'm sure this seminar is helping already. As a matter of fact, that's the next comment here. I don't have a question at this time, but living with HTN and asthma, I have a clearer vision and understanding for the future. So thank you.
You are very welcome, but I want to reassure you. So what you have is what we call essential hypertension, which is the systemic arterial side outside the lung problem. And if you take your blood pressure medications, you should stay away from affecting the left side of the heart with problems in the future that may lead to pulmonary venous hypertension. Similarly for asthma. So hopefully things will be in good control if you follow regularly with your doctor.
Terrific. Thank you. The next question, what is typically the age of onset for patients with pulmonary hypertension?
Again, depends on the group. We talked about that.
Right.
Older age group for group 2, younger for group 1. Screening is important for certain associated diseases and so forth.
The person that mentioned about the HTN, she replied perfect to your
Okay, great.
to your answer. And we have another thank you for the information. So we've come to the end of our questions. We'll just give it another beat in case somebody has an additional question, but really fantastic, Dr. Dahhan. We appreciate your expertise. And I'd
Very
like to
welcome.
mention to our attendees that you'll be speaking again in November, on November 19th, on the topic of pulmonary embolism. And you'll be talking about prevention and care strategies for that. So we look forward to your next event, and we thank you for your time and expertise. As our attendee said, I concur. So thank you, Dr. Dahhan. You truly are the expert, and we appreciate you.
Thank you very much, and I appreciate it, and looking forward to seeing you again all. Thank you.